speakers. Good morning to our participants, webinar participants, attendants. Whether you are in Indonesia or in another country, good morning to you all. It's very nice to meet all of you virtually in the first webinar, MHPE, Master of Health Professions Education and Friendship, the FAMER Center in Indonesia. Yeah. Okay. I am Rokhmah. I'm here to invite all of you to join with the hopefully fruitful discussion this morning. And we already have our 3 speakers here, and also Dr. Yoyo Suhoyo, who is our Friendship Director. Thank you very much for joining us, and hopefully you will all have a joyful webinar. For the first thing first, I would like to invite Dr. Yoyo Suhoyo, our Friendship Director. Mbak Rani, you can turn on the screen for Dr. Yoyo as an director for the opening speech. Yes. Okay. Thank you very much. Dr. Yoyo Suhoyo, I would like to invite you for a short opening speech. The school is yours.
Okay, thank you, Bu Rokhmah. Hello, everyone. Good morning. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Rokhmah. Good morning, our speakers. Saurabh, Yudi.
Morning, sir.
Morning. And good morning also to all of you who are joining this webinar. Welcome to our first monthly webinar, MHPE and Friendship webinar. So you can join this webinar every month. And for today, we are going to talk about community-based medical and health profession education. So this webinar are conducted by Master in Medical and Health Profession Education and also Friendship. So all the speakers are students or alumni or of Master in Medical and Health Profession Education, or the speakers also will be the fellow or alumni of Friendship Fellowship Program. So it's a part of our activities in introducing, in promoting our Master in Medical and Health Profession Education, and also our Friendship Fellowship Program. So if you would like any question about regarding the Master Medical and Health Profession Education or Friendship Program, you can ask directly during the webinar. Also, you can visit our website. The goal of this, besides to introduce and also to promote the Master in Medical and Health Profession Education and Friendship Program, is also part of our activities in together in improving our medical and health profession education. So during this webinar, you can learn from our speakers about what they learned during Master in Medical and Health Profession Education, and also what they learned from Friendship Fellowship Program. So that's all for me, I think. Enjoy the webinar and have a nice day to all of you. Back to Rokhmah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Yoyo, as our program coordinator of Friendship. For those of you, Ibu Bapak, Friendship is FAMER Regional Institute of Indonesia for Educational Development and Leadership in Yogyakarta, Indonesia. It is part of the FAMER Institute from Philadelphia. And for those of you educators who are interested in improving your leadership skills, and especially doing or implementing innovation projects in your institution, we invite you to join the Friendship. I would like to start the morning webinar by saying hello to our speakers here. First, we have Associate Professor Saurabh Shrivastava. Good morning, Professor Saurabh. And also we have Dr. Siti Rokhmah Prodjosasmito and also Dr. Yudi Feriandi. For the first presentation is by Associate Professor Dr. Saurabh Shrivastava. He completed the prestigious FAMER Fellowship with distinction from PSG Coimbatore FAMER Regional Institute, India. He is the Associate Dean of Research of Campus at Sri Balaji Vidyapith, Puducherry. He is the Medical Education Coordinator and Curriculum Committee member. He is also the Editor-in-Chief of the Journal of Basic, Clinical, and Applied Health Science. He is an active researcher with more than 1,240 publications. You can see his publication everywhere in the database. You can check to his credit, and the author of 26 books and 3 chapters. His indexing status publication is 170, 513 from Scopus, and 467 in Web of Science. He has more than 4,000. It's almost perhaps 5,000 citation and 24 H index and 61 I-10 index to his credit. He's an editorial board member in 12 international journals, including BMC Medical Education, and peer reviewer in more than 130 reputed journals. Interestingly, this is also our question to him. He's currently enrolled in MHPE Universitas Gadjah Mada, which is very possible to do even though you are in India, right, Dr. Saurabh? And interestingly also, his contribution as peer for our Master and Health Profession Education students has, I think, contributed a lot to Dr. Saurabh and himself, and also to our other students from Indonesia. In this opportunity, I think we also invite for our educators around Indonesia, across Indonesia, or perhaps ASEAN and other countries in Asia. If you would like to enroll in our MHPE program, it is very possible for you to be our international students. I would like to invite Dr. Saurabh to present his presentation about his project in community-based education. The screen is yours, Dr. Saurabh, please.
Thank you so much, ma'am. Thank you for warm welcome and giving me an opportunity to be a part of this session. So it is this is mainly my experience sharing as part of whatever we have been doing in our institution. So the topic that I have taken for today's session is implementing early community exposure through health appraisal by rapid techniques. So we have given it as a small abbreviation, HEART. And as the name suggests, we are trying to appraise health of community members by using some quick techniques. So that is why this thing has come. And during the course of presentation, I will be telling you about what we all are going through in last 3 to 4 years. So to start with, uh, we introduced in our country competency-based curriculum for medical students. And as a part of this curriculum, we allocated a specific number of hours to each professional year for our specialty, that is community medicine. So in first professional year, we had 52 hours of teaching, which has been allocated. And like that for second professional year, 60 hours, and then third professional year, 105 hours. So eh, what we thought is that why we should always have theory sessions. We should always give an opportunity as well as experience to students in different forms of activities. And therefore, as a part of early clinical exposure, which can also happen in definitely in community settings, not only in hospital settings, we thought we will go ahead with a different sort of approach. And there came the origin of this program called as HEART, which also again stands for Health Appraisal by Rapid Techniques. As mentioned, it is an innovative community-based experiential learning opportunity, which is exclusively done for the first professional year students. That means those who are recently inducted into the profession of undergraduation medicine. And this program actually came in existence as we had collaboration that time with the Partners Medical International, Boston, United States of America in 2015. The basic objectives of this program were two. That is, first, we wanted to expose students to the biopsychosocial dimensions of health and disease so that students can understand how health and how disease happens, which is very much different than the hospital centered learning. And second thing, at the same time, we wanted to expose the students to research by giving them some insights about basic research methodology. So with that, I'll just tell you about the structure. It is actually a 6-day program that is from Monday to Saturday. And on the day one, we orient students. We give the overview of the program, what is going to happen with them over the next 6 days. We also expose them to basics of quantitative research and qualitative research. We tell them about what is participatory rural appraisal methods, some orientation, and I'll tell what all we'll do. We explain them about the importance of communication skills. We teach them about a family survey form, which they have to do as part of their community visit. And we also train them in using an EpiCollect mobile app, which is nothing but an app to collect data in field with or without internet. Now, finally, we divide the students in a group of 25 each because we have around 250 students capacity. So 25 each are divided. Then in field visit, that is next 3 days, students spend their morning time in field visits where they are exposed to different kinds of participatory rural appraisal methods. And I will show you them with the help of pictures to make it easier for you all. So different methods are there: transact walk, social mapping, key informant interview, cobweb analysis, seasonal calendar, 24-hour calendar, Venn diagram, and family surveys. In the evening, they prepare charts, model, posters, and even a presentation. Even day 5, this all activity happens. And finally, on day 6, there is a presentation day where they have to display their all the work. The judges will come for assessment. They will make a group presentation, and feedback is obtained using Google Form, some innovative feedback called selfie feedback, as well as verbal feedback from them, and then a valedictory function happens. So without this is the various essential considerations. So as I already mentioned, we divide the students into 10 groups of 25 each, and each group is assigned one facilitator, either a faculty member or even a postgraduate student. We share them with the multilingual vocabulary with students. So this is something which our university has developed because we receive students from different parts of the country and they all don't speak the local language, that is Tamil. So this is a reverse translation also, English to Tamil, Tamil to English. Even Hindi option is there. And to ensure group dynamics, what we do is that we pair students who can speak local language, that is Tamil, with students from other part of country so that they can learn from each other. And as an essential part of this, what we do is that each family which is allotted to student, they remain, these family remain with the students for the next 5 years, which is what I think even happens in uh, UGM. At the same time, we also request students that they have to reflect about their uh, experiences in the logbook. So with that, I'll just show you all the pictures. So the first method which we use is transact walk. So as the name suggests, it is like uh, wherever village, which village is allotted to them, student move around across various lanes to see what all important structures are there in the village. So all students go through, observe where is the hospital, where is the post office, where is the school, something like that across the lane. So nothing but it's a quick method where they will just walk across, make an important note of all important structures which are there. Next comes key informant interview. Key informant interview is nothing but they will identify an important person in the village. It can be a priest, it can be a post office person, a bank person, or even say a teacher or a health worker or a doctor. and then they go and interview them about important aspects in the village. Next is something called as a family survey. So where they go and obtain, students are instructed, as I told, day one, they are oriented about family survey form. And they not only fill it for a record purpose, but also they will do in the mobile app, that is EpiCollect. Moving ahead, this is nothing but social mapping, where, as the name says, uh, local villagers are instructed or requested to come and draw important structures in their village. So you can see in the various pictures that these are from different villages and different students, that villagers using locally available resources. These colors are nothing but called as rangoli in India, where they draw use it to make different structures as part of a daily routine or even in some functions. And they denote village farm with the help of green leaves, different colors, directions are also there. So this is how it goes. The important thing is that students should not do this. It is a participatory rural appraisal methods. So what we expect is the local villagers should participate to do this. The same thing is depicted in the form of models, so which students are expected to make in evening. So various important structures are there which they have to make as part of social mapping. These are nothing but other things like cobweb analysis, where they grade the importance of each structure in the village, like say how much is education important, facilities for education in the village. So based on that, cobweb analysis is drawn. Similarly, a Venn diagram where the important structures in the village are made. The size of the circle, you can see various circle. So the bigger the thing, like for example, here green indicates what is that called? Farm. So green is the biggest circle, and like that, temple becomes smaller, home becomes smaller. So whichever is carries is the biggest space in the village will be the biggest circle. And the last one is the force field analysis. So this is something which probably we all will be aware, where we focus on the positive and the restraining factors for any factor, any condition in the village, and the villagers have to come out. So for all these things, women will be interviewed, women or men, important people, and then we derive the analysis. Next comes something called as 24-hour calendar. So this can be drawn for a different people. Like for a pregnant woman, what they do over a period of 24 hours, when they rest, when they do work. This is for a next one is for a common man. What time they sleep, what time they get up, what is their daily routine, when they spend time with the family members. So this is nothing but 24-hour calendar. And next is seasonal calendar. So if I don't know whether you can see, but in column wise, these are the months, that is January, February, March, April, like that it goes. And various other things have been drawn in the rows. So how will be the climate, what all festivals they have, disease patterns, which diseases are more common, the crops that are harvested. So what students have done, they have brought different crops and stuck on the chart. Seasonal income, expenditure, food habit, all those things in the form of entire seasonal calendar, also like a yearly calendar. So next is on the last day, students come and they present about their group activities and what all they have observed. They reflect also. Then there is a presentation in terms of what all they have drawn, models, posters. So all these things go ahead, and finally we felicitate them, the best performing group. And I will just end my yeah. One more thing is there. As I told, there is something called as selfie feedback. So what we do is that we ask students to draw this structure on a piece of paper, A4 paper. If you can see, this is a face with the four limbs, and each limb has been graded in the scale of 1, 2, 3. So here I have not written on the legs, but even lower limbs will have 1, 2, 3. The important thing is that the face, so-called smiling or this, is not there. So this we achieve with the help of the next thing, which is there are four attributes on which students have to rate their 6 days experience. So first one is say
Yeah, yeah.
participation. So we will ask students whether they
Yeah, you can continue.
Yeah, ma'am. So whether students have an opportunity to participate in this 6 days program, it can be in any way, whether it participation in framing models or participation in doing some activities. Next is understanding. So what, in your opinion, how you would rate your understanding about participatory rural appraisal methods in these 6 days? Then what do you feel about or what is your attitude towards working after you complete your 5 years of training program in rural area? And finally, skill development. In your opinion, how do you think that your skills have developed as part of this 6 day program? It can be anything, say presentation skill on the podium, or say making PowerPoint, or doing interaction with community members, or filling say Epicollect mobile app. So anything. So students have to rate it on a scale of 0 to 3, and then they have to make a overall this thing, total it, and this is how inference goes. If suppose a cumulative total goes more than or equal to 9, they will make a happy face here. So this will become a happy face. If it is neutral, that is the grading is 5 to between 5 to 8, they will draw a straight face. And if it is less than 5, so they will make a sad face. So this is an innovative kind of feedback which is called as selfie feedback that we have been using in our institution. And I'll conclude my experience sharing with the help of a video. Thank you so much. That's all from my side. Thank you, ma'am.
Thank you, Dr. Saurabh, for presenting. I think that's very interesting approach to family medicine in community. I would like to invite all the participants to ask questions, or would you like to write the question in the chat box? Silakan Ibu dan Bapak jika ada pertanyaan. boleh dalam bahasa Indonesia, nanti akan kami bantu untuk menerjemahkan ke dalam bahasa Inggris. Boleh ditulis pada chat box atau pada langsung raising hands. Is there any question or comments from the participants? I think before that, I would like to congratulate you first for this innovation, and I think a very interesting approach, which perhaps give a very good impact for your students. Can you share what did they find most interesting or most impactful experience for them, for the students?
Ma'am, actually, most of them come from cities. So going directly to village itself becomes a very this thing for them. Plus spending time over there. This is again like they all are huge number, ma'am, 250 students, and they don't get opportunity to gel with each other. So I think this gives them opportunity to bond with each other, come out of their comfort zone, because we divide them, we don't keep them in their friend circle. So students get an opportunity to learn not only from the members of community, but also from their friends. They get to know what are the strengths, weaknesses of their friends, how they can complement as a team to each other. And experience never, this remains always useful, ma'am, because this is something which generally doesn't happen in most of the institutions. So it is quite new. I should say hardly one or two institutions offer such kind of experience in India at least. So this is something unique for them to learn something which is very quick. They don't have to invest a lot of time, and everything is from the people, for the people, by the people. So it becomes useful. They learn how best they can do. Thank you.
Congratulations once again.
Thank you.
Yeah, and I think that's one of the challenge where our students, medical students or other healthcare professionals, their schools are at the cities, at sometimes big cities, metropolitan area, and they at the end of their education, they need to also serve the people at the rural area or other communities where it might be very different with what they already experienced before. And I think this is one of the way to expose them to the challenge in the community. Okay, while we're waiting, I think we can move on to the next presentation. We have a question here from Pramana, Imade Pramana. Could you tell me about the health problems that the students can learn from this program? Thank you. Please do, Saurabh.
So thank you for the question. They not only means there are before coming to the health problems, actually they learn about the lifestyle of rural people, how they live, what all the factors that determine or define their health, well-being, and even the factors which are there or not there, because of which they suffer from any kind of disease. So this is a unique opportunity for them for students to be the bridge between the local community and a tertiary referral center like a medical college, because generally people are not so much convenient in coming to the tertiary care hospital, especially if it's a private one, because they always have financial constraints. So here in that case, it becomes very useful for institution students to be the one, the change agent here, where they can take care of this disease wise, health problems wise. They will come to know about malnutrition which is there prevailing in the community, common kinds of disease like in what season specific disease is present. The common disease like in my area, filariasis is quite common, endemic I should say. So what factors make it more important? Then other things like infestations, being a village, snake bite, poisonings, all those things are quite common. So yes, ma'am, I think thank you so much. I have one more question. Shall I answer, ma'am? I don't know. Yeah.
You have actually two more questions.
Okay.
Well, the next is very interesting innovation to teach students in your community, Dr. Saurabh. Could you please explain the models and charts, what they conclude by doing that, or what activity? That's from Dr. Elizabeth. Swasti Nugrahini. Thank you.
Okay, thank you, ma'am, again for the question. So actually, I told it's an experiential learning thing. So whatever they have learnt in their in the field, that they have to replicate in the form of a model or a chart. So this is not only, maybe I should say, a thing of remembering what all they experienced, but again, this teaches them about teamwork. They divide their work accordingly, and each member is given a specific responsibility by the leader in the team, and then they all work together for specific things. What they actually learn is they revisit whatever they have seen in the community and how it is important for local people, and this then remains with them for the next 5 years, because as I told, they have to follow up, each student has to follow up the allocated family for the next 5 years. And as we say, first in impression is the last impression, so this will help them to stay connected with them in future, because it's a longitudinal or a cohort kind of thing where they keep on visiting. I think in the first year itself, they have to visit 9 times to the allotted family. So this becomes a good experience for them to build upon the experiences, and at the same time advise them what they can do to not suffer or have a healthy and good quality of life. I think that's it. Maybe, ma'am, I'll go to the next question. Do the student face difficulties related to culture or Definitely, yes. It is bound to happen, and that is why I said at the beginning that this is an opportunity to not only expose them to the community, but also for them to come out of their comfort zone. Because what we are aiming is we are trying to provide contextual education, which is the need of the hour. We can't teach, say, if I am in India, I can't teach them the books or the syllabus which is followed in Europe or in America, because they have different kinds of problem. So our idea is that they have to get exposed to, and that is why early clinical or early community exposure came into existence, where we have to make them understand, because they will be the one who will be dealing with the patients in the next 4 or 5 years, in even during internship. So they have to know the communication, that is the local language, and the culture which is responsible for the common diseases that are prevalent or found over there. So this is definitely, they face problem, but unless they face problem, they will not take efforts to learn. So that's it. Thank you.
Thank you, Dr. Saurabh. I actually got another question from Burina Sumaratna. It's directly to me, so I will read it for you. During the 5 years, do the same students follow the community based on each household or specific family? I mean, do they attach to the same family through the years, or do they change their, let's say, our partner families or communities? Yeah.
No, ma'am, they stick with the same family for the next 5 years. It remains same, so that bonding remains with them. And yeah, same concept as partner families, ma'am.
Thank you very much, Dr. Saurabh, for the presentation. I think it is one of the new insight about best practices in community-based education practice. And our theme for today's webinar is changes in community-based education practice. Dr. Saurabh is one of the leaders. We invite him as a leader in the community-based education in his institution. And next we will have Dr. Yudi Feriandi, who is also a leader in his institution in the supervision. His project is about the supervision in community-based education practice. Okay, thank you very much, Dr. Saurabh. Please stay until the end of the webinar, because we will have a discussion later on. Okay, Dr. Feriandi, I would like to introduce him. Dr. Yudi Feriandi, MHPE, is the general practitioner in primary healthcare clinic. He's also he's been involved in various management whether it's at hospitals or primary care, as a senior manager healthcare at Rumah Zakat Indonesia Pusat, chair of Rumah Sehat Indonesia Foundation, consultant in hospital management, the directors of Permata Mana and Permata Zibuhuan hospitals in North Sumatra. And he's also an active lecturer at the Faculty of Medicine, Universitas Islam Bandung since 2012. Recently, he graduated with distinction. This is also only one of his degree. He had many degrees aside from the MHPE. He graduated with distinction from MHPE Universitas Gadjah Mada 2023. One of his project that he's been actively involved, projectnya Dr. Yudi yang sudah sangat digeluti sejak lama, is about supervision in community-based education. And hopefully this will also give us insight on how the supervision will go. Dr. Yudi Feriandi, please, the screen is yours. Thank you.
Thank you, Dr. Rokhmah. Okay, please, Allah permit me for the screen sharing. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you, Dr. Rokhmah, Dr. Yoyo. I see also Dr. Doni, my supervisor, and also my lecturer during my postgraduate study in UGM, and also facilitator in friendship that bring a lot of new insight in my life, actually, not only in work, my daily working life. So today, actually, my project in Weimar is about interprofessional education, but I see Dr. Rara take the EPA, so I think the EPA from Dr. Rara will be more give insight for us. And actually, my EPA not really yet finished because now in the pace of advocating to the rectorate. So in program study, we try to implement the IPA now in the clinical stage in the clerkship, not yet in the academic phase. But today I would like to share about my thesis. This is actually a project. At the beginning, I want to make this as a Weimar project, but because of the challenges and the obstacles that we will face if we implement this project, that will not be finished maybe in 1 or 2 years, because changing the paradigm from the traditional assessment into the new paradigm of the programmatic assessment is quite challenging a lot. And I also take this thesis not in my own institution, but in one of a private medical school in West Java. So I will not explain to or share to all of you about the community-based education. I think we already know what is community-based education, but I would like to share the other perspective, the supervision and mentorship in community-based education, but in the programmatic assessment readiness perspective. So as we know that in the medical education, we face a lot of changes. The changing in the curriculum, teaching process, and the assessment system. And nowadays, we are facing, especially in Indonesia, we now integrating the programmatic assessment into national program. I think everyone here and their own faculty also have the involved in what Prof Mora, I think, as the leader, to change the assessment into the more longitudinal integrative ways of assessment. And this is also challenging also for the community-based education. So I want to combine the community-based education and also the new assessment principle and try to find what is the hindering factor and what is the enabling factor. Do the programmatic assessment could be implemented in the community-based setting? This is what my curiosity during the program in the postgraduate study in the UGM. So based on the changes, I try to capture with my supervisor about the fundamental concept of programmatic assessment and how the single assessment, as we know that in the previous years, maybe we say that the students is graduates or not based on the final exam, and the final exam become the only one high-stake decision points to say that our students' competence or not. So in the programmatic assessment, all the old paradigm changes. So we use the not only multiple assessment, but we put the assessment such as an instructional design, such as the curriculum itself. It's have a pattern. It's have several data points that we have to consider, not only the final exam to say whether our students graduates or not. And in programmatic assessment, most of the university or faculty or programs that using the programmatic assessment use one of tools, one super tools, then develop from times to times that we call with portfolio. And nowadays, the portfolio not only just to record what the students achieve during their learning, but also it becomes the summative evaluation or high stake, the formative evaluation or low stake in programmatic assessment become the tools for reflection, and also reflection will be automatically, ideally combined with the feedback from the mentors and also for self-evaluation of the students itself. So the portfolio is one of the promises tools if we take the maximum advantage to deliver the supervision and mentorship process during community-based education. So this become my final thesis, how to implement this programmatic assessment. Maybe I will not explain also about programmatic assessment because we already knew, I think, these trends, especially in Indonesia. This is the programmatic assessment. Okay, we can read. So there's no more summative or formative, but every assessment is a single data point that have to be considered. So the formative and summative portfolio in the previous concept of medical education assessment now become the portfolio in programmatic assessment, which the principle of longitudinal, constructivist, and integrated with the curriculum and the assessment process itself. So the portfolio in programmatic assessment that will be implemented maybe in the community-based education setting should be a tools for diagnostic of the students' learning, should be the therapeutic to assess and to treat the students' deficiency and competency, not at the end of the program, but since the beginning, the intermediate, and before the end of the program, and also the prognostic. Since the beginning, we can predict the success of the students in our program. Okay. So this is the model proposed by van der Vleuten, and we try to capture the component of programmatic assessment, previously using the tools from Dr. Dina Kurotain. She was the previous, and this is the existing community-based education in primary healthcare rotation model setting in one private medical school in Indonesia as my place for research. They have 12 weeks to conduct the primary healthcare rotation for the clerkship students, and almost the same with ours also. But in Unisba, we only 8 weeks for the rotation. So this rotation, this concept, this model, try to be assess the readiness to use the programmatic assessment. So that's we involve total sampling of 58 students that already finished the rotation. And also we involve the stakeholders and also the lecturers. So this is 360-degree research model, I think, from the perspective of the sample. So it's the powerful of the research itself is involving all the stakeholders involved in this community-based education rotation model. So this is the flow of the research that we conduct. And then this is the maximum variation sampling. We try to capture from the different characteristic of the primary healthcare, what we call in Indonesia Puskesmas. And this is we use also not only quantitative, but qualitative with focus group discussion and semi-structured interview. We use 3 cycles of FGDs to increase its validity and reliability in qualitative data. And then we found that something interesting. At the first, we want to capture about the sporting activity as the supervision and mentorship. But during the analysis, we found another that very related with supporting activity. It's intermediate evaluation. These 2 components, 2 from 5 programmatic assessment components, is very related with supervision and mentorship readiness in community-based education in our setting. And then if we dig more deeper about the subcomponents, we can see which one is the student perception that we are not ready yet to implement the supervision and mentorship in the framework of programmatic assessment. We can see the strongly disagree. I have put several boxes there. The feedback based on portfolio rating. They have portfolio, but it's not written based on feedback. And feedback itself should be based on the reflection of the student. This indirectly capture that the use of reflection, feedback, supervision, and mentorship not yet implemented well in community-based education in these research settings. So this is the challenges. And also the reflective writing skill of the students. This is, we can see that some of the students say disagree and strongly disagree that they have no good reflective writing skills. So this become also in my university in Unisba, we try to make the reflective writing skills as one of the skills lab in our study skill during the first semester. So the recommendation for this research is to please teach or train the students about the reflective skills earlier. The more earlier we teach the reflective skill, the more reflective skill practice can be implemented in our students. And then the reflection of good learning achievement it's related with the reflective skill, reformulation of the learning plan. This is related with the MCTQ questionnaire that we also use in quantitative base, that the exploration, perception of the supervision is quietly low in the student profession. We can see the next slide. And then the learning plan monitor from the mentor. So that's why we use two tools during our research, the MCTQ component to capture the supervision and mentorship based on quantitative data, and the programmatic assessment readiness, how to capture this deficiency and also the enabler factor using other tools. So it could increase the validity of the research because we use the different tools with the same result at the end. And then scheduled mentoring session is still become the obstacle, and also the continual feedback. The feedback still not continue. Most of the students say that maybe it's quite good, but 19 plus 2, 21 students say that the continual feedback. So we not only capture the consistency, but also the variance between the mentors. Maybe the 25 students say that our mentors is good to give continual feedback, but the others not. So we can say that this is the variation. We can also see from this quantitative data that it will be digger more deeper in the qualitative phase. So that's why we use the mixed method to dig more. And it's the one of the extraordinary findings actually. We try to capture the cohorting activity, but the result of the research say that also the intermediate evaluation components not already established well. Why? Because the intermediate assessment in the programmatic assessment can be used as the intermediate tools for prognostic, for therapeutic, and for diagnostic students before they ended their programs in the CBE. So we can make some modification in their learning. We can make learning plans together to achieve the deficiency during maybe the first half of the rotation. So at the end of the rotation, they could achieve the deficiency with more efforts based on the intermediate evaluation. And if we see the box here, the 4 boxes, existence of intermediate evaluation, not yet, the students say that this is because like mini GX should be implemented in the 2nd or 3rd week, but the lecturer put them on the end of the rotation. So because the mini GX, it's the communication tools between the students and the mentors and the supervisor to assess, not only to grade them by value, but also to give them the feedback and reflection. What deficiency in their skill, what deficiency in their learning or competency at the medium or at the middle of their rotation. And then another, this is the MCTQ finding. So the supervision quality gap, we can see here the exploration is related with the finding of the continual feedback, of the renewal, their objective lesson plan after the feedback and reflection. Can we see that the student put the exploration not at the top? So this is based on which is the highest score based on the mentor's perception, and which is the highest score of the supervision quality gap from the student perspective. We can see the exploration, and when we put it in the quantitative analysis using the statistical Mann-Whitney, we can see that it is significant. And also the general learning climate. This is the academic atmosphere in another definition. So from those 2 tools, we can also say that, so this is the quote from the students. To be honest, I was under the portfolio session, learning material that had to be completed, so we didn't make it like that. So the portfolio is just obligation, not the tools for reflection, feedback, or to assess the deficiency, or also to assess what the student have achieved. So there's no feedback from me personally. This is from the perspective of the mentors, reflection on each day's activity after mini CX and DOP. So the mini CX, the intermediate evaluation, is just only summative. They only give the value A, B, C, or the scores, but not the feedback itself. So this is very congruent with the findings in the quantitative phase. So, and then we try to find the qualitative phase. What is the enabler and hinder factor from the 3 FGD cycle, and also from 1 session, 3 session with the semi-structured interview with the stakeholders, with the medical education unit coordinator, with the public health department coordinator, and also with the program head or the clinical rotation in CBE. So the enabler factor They have the conducive learning environment, primary portfolio implementation that maybe can be more just in the future using the programmatic assessment and the findings in the research. And then the mentor commitment. They have commitment, but the mentors say that they lack of skills how to be a good mentor. So this is the recommendation to make some training for trainers of the mentors before they become the mentors in the CBE rotation. And then the existing multimodal assessment method, they have mini GX, mini DOPS, final examination. It's good starting point. Just another way have to be implemented is put them not only formative and summative, but low stake and high stake with the optimizing all the data points for student competency monitoring and feedback. And the existence of feedback practice that has to be still have a variation between mentors. And see several hinder factors. The portfolio is not ideally to meet the programmatic assessment requirements and variability of the mentors as we see before, and the quantitative and qualitative data. Student readiness also, the reflective practice skill, the writing skills of the reflection, inadequate feedback quality, absence of formal peer mentorship. So this is one of the interesting things. So they feel that peer mentorship should be formalized, not only mentor from the supervisor, but also the peer can be mentor. And inadequate feedback quantity, the absence of collaborative mentorship practice, because during the rotation they have two mentors. One is from the primary healthcare and one from the institution, from the program. So they sometimes there's no good communication between two supervisors or mentors. So it become something that's unclear for the students which feedback that I should be follow then. And adequate formative assessment impact of the learning. They have many CX, they have those, but no feedback, no communication between the mentors and the student. So based on the finding, we try to propose a model of rotation that's suitable with the programmatic assessment. So this is the 12 weeks learning activity. And they use the workplace-based learning in community-based setting, and then they have assessment activity from the intermediate assessment. They can use also the tools that already exist to become the intermediate evaluation, but optimizing the intermediate evaluation to become the diagnostic, prognostic, and therapeutic tools as a communication tools between mentors and students is quite higher priorities, I think. And then the last is supporting activity. So this is our recommendation based on our finding about the hindering and enabling factor, and also the findings in quantitative and qualitative data. So that's the conclusion of this research, or maybe semi-project, not only research. It's important to assess the quality of supervision and mentorship in our CBE, to capture not only the quality, but also the variation between mentors, between supervisors, and also supporting activity of the program as a model to improve the quality of reflection and feedback during the program, because reflection and feedback is the core of the supervision and mentorship itself. And the third, formulation of action plan based on hindering and enabling factor for the supervision and mentorship. So I think this model could be a best practice, or maybe in the future could be more disempurnakan to be create more better than our models to be implemented in our community-based education setting. So we create the curriculum, we create the assessment method based on evidence that suit with our vision, our mission, and the trends in medical education to create a better graduates in the future to increase the health of the population. Thank you, Dr. Rokhmah. Maybe this is all my presentation.
Thank you very much, Dr. Yudi, for your presentation and sharing. I think it's also a challenge while choosing not only the methods, but also how to evaluate students' progress and how to ensure that their learning result to something, and then you can also identify it as one of the indicators for their learning as a whole. Thank you very much, Dr. Yudi. I would like to invite, is there any questions or comments for Dr. Yudi presentation? Silakan Ibu Bapak jika ingin bertanya. Any question for Dr. Yudi? While we're waiting for the question, I would like to ask Dr. Yudi, what is, I think it is very interesting that the supervision actually plays a big role in community-based education. And what would you suggest for the institution who would like to do faculty development for their teachers to be able to facilitate the learning and also assess students in the community?
It's very nice and challenging question actually, Dr. Rahma, because this research also still continue by me using the local action research, mini action research. I try to implement also the concept to the rotation in our faculty, and not tried enough actually to make the portfolio application program. So the first thing is when we try to develop the faculty development for our faculties, we have to measure first the need assessment for the faculty development, which gap should be monitored, which competency of mentorship or supervision from our lecture based on the student perspective itself and based on the mentor or supervisor itself. And then from the need assessment, we can find which gap is more prioritized or become the core of the faculty development that should be trained to the faculty. That's the first. So we try to put the faculty development not only a traditional way of that the faculty development should be A, B, C, D, E, F, G, but also we can push the gap and the priorities more to the faculty. So like the communication skill, the reflective writing, how to giving feedback, then etc. It's in every faculty development they must have the topics, but we should push the emphasis on several topics based on our own needs to fill the gap of the supervision and mentorship. I think it's the most, even in my own faculty, it's quite hard to implement the concept of programmatic assessment in short setting of CBE. But when I said that I will try it on my own student during the 8 weeks, using the Moodle as the tools portfolio and try to implement intermediate assessment during the rotation, and then at the end the amount of the student that have to come to remedial, I see it's only 2 from 12 students. It's quite good, I think. So this is my own practice, but I cannot make it as a publication for now because the sample is quite little. So maybe after become the mentor for 2 or 3 mini group, I will try to also make some manuscript also and share with the academic community, I think, Prof. Rahman.
Thank you very much, Yudi. And one of the key of the faculty development for, let's say, training teachers to facilitate learning in community education, I think, as you say, we need to know their needs, the teachers' needs, and also the current challenge. Since I think, as Saurabh mentioned before, every community poses different challenges for both students and also teachers. Well, we're still waiting for the questions that will be addressed to Dr. Yudi. I would like to invite Dr. Rara, so perhaps later on we can have a more wholesome discussion. Thank you very much, Dr. Yudi, for the presentation. And yeah, please stay until the end of the webinar. We will have a closing discussion later on. I would like to invite our third speaker, Dr. Siti Rokhmah Prodjosasmito, or we can call her Dr. Rara. Dr. Siti Rokhmah Prodjosasmito, Master of Education, obtained her medical doctor degree from Universitas Gadjah Mada and Masters of Education from Monash University, Australia. She's a veteran, I can say so, veteran as an internal auditor of quality assurance system at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. And she's mostly involved in research and training in faculty development, organizational and leadership, learning skills, and community-based education. Right now, she is also one of the chief editor at the Journal Pendidikan Kedokteran and Profesi Kesehatan Indonesia, or JPKI. I would like to invite Dr. Rara to share her best practice and changes in community-based education practice. The screen is yours, Dr. Rara.
Yes, thank you, Dr. Rokhmah, for the time. And good morning. Assalamualaikum warahmatullahi to all of you. I hope you are in a good condition. Please allow me to share my screen. Yes, Dr. Rara give me this title to share with you about the implementing community-based IPE to learn how to engage community. I will start with this outline. This is the outline of my presentation that I will introduce you the community-based IPE, a little glimpse of our CFHC IPE programs, and then my friendship projects, and then our post-pandemic learning in IPE, and then take-home messages. Yeah, as we know that IPE is a educational program that's connecting between different professions. Yeah, in our situation, we connecting 3 different professions: student from medical and then student from nurse, and also student from nutrition. But it's can happen with the different profession. IPE in our situation, we use the community as a placement area, but IPE also can be conducted in a clinical situation and also in an academic situation. IPE in a community can reinforce the student-centered learning process. That's the most educational philosophical that used widely in health and medical and health professional education right now. And it's also can be used to reinforce service learning, as we know that in our Tridharma, we have to combine between the education, research, and also public service. So a community-based IPE can be used to serve as the Tridharma process. Because by using the IPE, we can make a better connection between academic and healthcare service in community, but also can benefit for community and students. Besides that, in using the community as a placement area for the student, we can also use the real setting. The real setting used in here is the community, and they also can learn by their experience using the theory of experiential learning. They can also learn how to solve community health problem, and at the end of the day, they can master the IPC, the interprofessional collaboration competencies. Some of the advantages that I found in the articles about conducting IPE in a community. First of all, students learn and practicing the theory of social determinants of health, rather than just learning from the theory in their public health course. Maybe they can also try to practicing it during the IPE community-based IPE course. And also will improve the cultural competence of the students. Meanwhile, the activity also will improve students' value on community participation in health status. And the community-based IPE also can help students to learn about population health while practicing basic clinical skills during their program in the community, and also especially practicing teamwork inside clinical settings. All of this theory may be, I will try to discuss about this on how we put this theory into practice in our CFHC IPE. So this is the glimpse of our CFHC IPE programs. The CFHC IPE programs are community and family health care with IPE interprofessional education program is our faculty longitudinal curriculums. It will be conducted during the undergraduate program. For first year student, the second year student, the third year student, and also the 4th year student. Each year they have a different or distinguished goals or learning objective. For the first year, it put emphasis on the developing interprofessional teamwork and also developing the cultural sensitivity. During this year, student will go to the family, partner family, and then they will try to understand about the family problems, and then also they will try to know the family structure, the social structure, and also the structure of the village they live. And in the second year, it put emphasis on the family health. Students are trying to collect data to recognizing family risk factors, and from this data, after they analyze the data, they will try to make a intervention, a small intervention for, to lower the risk factor had in the family. And then in the third year, this one is the one that I will put emphasis during this whole presentation, is about the third year program. The third year program, it put emphasis on community health. So during the third year, a student will be will get more families, yeah. So it will belong to menjadi sekitar 10 keluarga. So they will be working with the desa wisma, that's what we call. And then they have trying to analyzing health problem in the community. They goes to the communities, they conducting need assessment. It's almost the same with Prof. Saurabh conducting in his program. And then they try to assign the priority health problem in the community together with the community. And then they try to designing and conducting simple intervention, community health intervention as the main goal of this session. And the fourth year, it will be, the main goal is about the emergency and also disaster readiness in the community. Why at the end of the year or at the end of the program, they will be, they are talking about, they put emphasis on the emergency and disaster readiness of the community, because emergency and disaster is our university strengths. So how about the education programs? The program is held as based on the theory of the community-based education, and it is also a project. And we also conducting community service learning during the, especially in the third year and also the fourth year. And then we made a community placement, but non-clinical, because students came to the family in the community, but not based on the primary health care. Yeah, so they are not coming to the primary health care, but they are directly come to this community. And then we have a co-facilitation between DPL and EL. DPL is dosen pembimbing lapangan. DPL is come from the faculty from our institution, and the EL or instruktur lapangan is health professionals that belongs to the primary health care in the designated area, yeah, from our community partner. For example, if our students is in the area in Ngagle, in the region, so the EL come from the primary health care Ngagle. And we already, during program, we already cover all regions in Sleman Regency. So all of 15 regions in Sleman Regency, we already been there. So this is the how we how our students try to learn community participation in the whole CFHC program. So they try by conducting the first stage during the first year, and also trying to giving the information, and then they starting to consult using during the second year, and also involvement also happen in second year. But then in the third year, we are trying to bring them to empower the community. So that's how we try to make our students learn step by step, yeah, not directly to empower the community because we have a longitudinal program. So we start from how they try to inform the community, and then move to consult, to involve, and at the end we can able to empower the community. The friendship project that I made during my fellowship, since I'm a fellow in 2019, there is a big change happen. Before, our program is a fully face-to-face program, but then there is a sudden change due to the COVID-19 pandemic. So there is a university shutdown. It's in the middle of the our student already planned a good community intervention, but using a face-to-face mode. But then there is a COVID strike us, and then they have to change directly to the online activities, and it's made some problems. Yeah, we found a lot of challenge during this year. Yeah, and the most challenge we got is that community partner leaving their consent. They don't want any longer become our partner in this CFHC program. Our student is confused because suddenly they don't have community partner, but then they have to conduct their community service, so they can get they finish their learning task. So we have to find another community or another family around their family's partner before, and with some help from the community leaders, we are able to solve these problems. However, we still find the challenge, even though they are willing to join during the COVID pandemic. However, we found that there is a gap on technology acquisition on family partners. So not all of the family partners are familiar using the WhatsApp, even only for WhatsApp, and then they are not familiar for using the Google Forms. They are not familiar using the Google Meets, Zoom, or even WebEx. So it's give a challenge for our students, and also because the daring situation or online situation, the participation of the family partner is quite low. So they are involved very passively in the program. Yeah, sometimes they answer, but sometimes they are not answering anything, or they are not giving feedback to the groups. And we also found that there are missing family partners. Yeah, because the family partner suddenly cannot be reached out through online communication. And this my year one project, because it's still in 2020, the COVID angka kematian, angka COVID-nya cukup tinggi, so we cannot ask students to come to the community. So we have conducting fully online. So we we ask students to put those on their reflection and also their evaluation why their program can say that it failed, something like that. So we as a directors, we try to be more flexible. So if they think their program failed, they just have to make a reflection and evaluation why the program failed. So we are receiving whether the program failed or success. So from those challenge during the year one, we get the some lesson learned that community service should be planned based on the community partner condition. That because first of all, they plan conducting a face-to-face activity, but then there is COVID and they have to change into the online activity. Of course, there is some problem in this changes, and then we have to understand on community technology literacy before conducting online program. For example, one of our students, because one of the teams because they are very excellent in our student is very excellent in the technology literacy, so they make a very good programs, but then because of the gap with the community partners, the program is not running, because the community feel it's quite hard because it's quite hard only because of the technology, so they don't want to continue the programs. And then continuous communication with the family partner is needed to reach sustainability of the program. Because of those changes, we need more intense communication with the community partners. There is some change in on the rules to conducting activity in a community, so we have to change the way we communicate to the way we conduct the community service also. And good communication and collaboration are needed to successful program delivery. This lesson learned we got because of there is some like disturbance in the communication between our teams and also the student teams and also the family partner, and also we found it's quite hard to maintain the communication due to the sudden change, but because of good collaboration between all of those components, even though it's not 100% successful or 100% conduct like what we planned before, but it is still good. At least we still reach our final goals. In a year two, we use the recommendation from year one that we need to make some new recruitment qualification for family partners. For example, we need to put only family partner with a good technology literacy. They have a facilities to conduct online communication. For example, they have at least they have a mobile phone, they have enough data, or maybe they have a Wi-Fi connection in their home and something like that. So we improve the recruitment qualification for family partners. And we also preparing best practice and module for student and facilitator, especially for conducting online health education and also online communication. And we also developing protocols for face-to-face activity with family partner, because even though it said that because of COVID we cannot meet face-to-face, but we can fully conducting in online. There is some activity that need to conducting face-to-face. So we are making some protocols to conduct face-to-face activity. So during the year 2, we are working together to change the face-to-face activity into online activity. We try to design a full online activity, even though, as I said before, that at the end, we cannot do it in a full online activity. But some of it is still limited face-to-face activity. And then we develop a learning resources that the content is about tips and tricks in conducting online health education, and also tips and tricks on conducting communication, online communication. And we also trying to recruit communities based on the interest. Beforehand, we always recruit community partner based on the geographicals, like I said before in the previous slide, that our program is conducting in the Sleman Regency, right? But due to this situation, and we cannot recruit all of the family partner and community partners from the Sleman region, so we trying to innovate the community partner by recruiting communities based on the interest. Some of it examples of this kind of communities is communities of basketballs, and then community of what we call it, ibu-ibu sekolah anak-anak SD, kemudian and then also student who live in a asrama, in a dormitory in UGM. And then also we develop protocol for field learning. And from these changes that we try to make, the results at the end of the year in our evaluation, we found that the learning site is changed, that we use the Sleman regions, and then we use a special community, and we also have to use the community outside Yogyakarta. We have to be very flexible this time. It's in 2021 while the rate in morbidity rate in COVID-19 is high. For the Sleman region, we use our usual community, and then the special community is as what I mentioned before, and the outside Jakarta community is for the student who cannot join the community in Jogja. They cannot join their groups in Jogja due to their limitation in online kind of kesulitan sinyal sekali untuk join dengan teman-temannya yang di Jogja, so they develop their own community in their hometown. The intervention used by students to conducting the community intervention is webinar, and then social media campaign. They use especially in Instagram, and then they made the online health challenge. The online health challenge is their tools to make a community empowerment during the COVID pandemic. They usually ask the community partner to upload their daily activity, like the physical activity, eatings, their daily meals into their groups, and then they will give feedbacks. And then they also give a kind of reward for the community member who have the best in their daily activities. And the topic they discuss is about the non-communicable diseases-related health problems and healthy diet. The response from the community actually good, but the dropout rate is quite high. For example, they start with a community with around 10 until 20 members, but then at the end of the program, they only have 3 members, 5 members, or the best is I got is I think it's about 10 member in one community left at the end of the program. Yeah, the lesson learned that we got that IPE team must develop the community environment program based on the community felt need and not limited to community normative, comparative, and felt needs. Of course, to be able to reach that, student needs to be equipped with the knowledge and skills to conduct community need assessment. And the media and mode of delivery for intervention should be chosen based on the participants. Simple and easy to follow program will help community to engage with the program. Yeah, so when the students develop media that it's quite complicated, especially in the term of the technology used, the dropout rate is quite high. But when the student use a more simpler way and more appropriate with the community, their community partners, so it is the dropout rate is quite low. And the community with strong social capital, bonding, and trust actively participate in the intervention and challenge. Those support the successfulness of the programs. As we monitor and evaluate the program, it seems that the communities that based on the geographical area, which is the communities inside the Sleman regions, has more dropout rate rather than the community due to the same interests, like the communities of basketball athletes, the communities of the marching bands, and the communities of the dormitory students, and also the communities of students, primary school students' parents. Yeah, they are more active rather than the community from the region based on the geographical regions. And then build strong and strategic communication with community leader is one of the facilitators to improve community participation and reachability. We found that when we have like a key person in the community, like for example, we have a good relationship with the Pak Duko in the community partner, or with the kader in the community partners. So we are more easily to communicate with the communities there, yeah, and they will give us a strong support, yeah, they will motivate their community to actively involve in our program. In the post-pandemic learning, we are come back to our original design with some improvement, of course. So beforehand, we are more face-to-face activities. So we are changed to the lecturers is now conducting in a synchronous and all asynchronous activities. The synchronous, we can do it in a face-to-face, and also we do it in an online situation. So it's more flexible. And then we conducting the induction with community partners. In the induction with the community partners, we are conducting this with the face-to-face session, also with the community, with the community leaders, with the PL, and also with EL. So we are doing together with the students. And then we having a role play for preparation. And the need assessment is very important part of this year 3 activity. So we conducting role play first to prepare students to be able to conduct proper need assessment to the community. And then student will come to the community. They will conduct need assessment and determination of health problem priorities. During their, they usually use community meetings to conduct this need assessment. So they are not coming to every family, but they try to they ask permission to join the community meetings, and then they conduct the need assessment during those meetings. And after that, they will try to analyze, and then they come back again during the community meetings, and then they, together with the community, they have to determine the problem priorities, and also try to determine what kind of intervention they want, they want to conduct in their community. And then students come back to the campus and try to develop the plan of action of community service. And after the proposal or plan of action is being accepted by the PL and also EL, they will conducting and evaluating community services. They will conducting the community service with the community become the leader. Actually, most of the leader community will try to empower the self, student trying to empower the community by the activity they design, and then they evaluate the result of the intervention they meet. And at the end of the day, we will make a dissemination of the community service result. It's usually student will make a kind of a poster presentation, and it usually happen in our campus. And we also invite the community leaders from the community partners and also the community. And we also make kind of a awarding moment during this dissemination session. So the best community service conducting by the student will be rewarded. And we are very happy because of it, because of the reward. Yeah. And all of this situation is conducting now in a blended learning environment, and we are very suggesting, we give a strong advice to students, and we also conducted this in a management, continuous communication with the community partners. So we ask students to not only say hello to the community partners during the session, but so outside the session. They usually have groups with the members of the community partners, and then they also came if there is some situation happen in the community. For example, if there is some activity that they want to follow, they are also joining the activity, and they also came when one of the community member have a berita duka, so they will came to them also, and etc. And with this all of this condition, at the end, the result, we found that community engagement is increased, and the number of the program that empower the community is also increased. And the most surprising us, one of the team, even though it's only one from 90, but I think it's very exceeding our goals, is one of the teams is able to make community entrepreneurship programs during their communities learning. So this is a very, very surprising result that we got. This is the sixth take-home step. I found that I put two about collaboration, that learn to collaborate interprofessionally in community setting can give set of capability to students to work within community, which is very needed after they finish their or graduated from our program. And then collaboration between community partners and the institution how the program must be maintained continuously to ensure sustainability. So if we want to our program is sustainable, so we have to maintain, even though our student is no longer in the region. I think we as the programs manager or the program director still need to maintain the communication with this region. And then program developers must facilitate students to design programs that empower the community partner to ensure the sustainability. So we want the program developed by students can be sustained in the community. The community can continuously conducting the program that initiated by our students. So we want our students have a pride, yeah, have a more, and then develop more confidence to join with the community later on when they are graduated. And then the communication between institution, community partners, and students should be continuing in the whole period to build bonding and trust. So if, because when the students are not actively communicate with the family partner or community partner, we found that it usually they will drop out from our programs. Then the learning objective and goals of the program help course developers, students, and others involved in this program to adjust the program on unpredictable situation, like what happened that we experienced during the COVID pandemic, that because of the clear objective and goals is clear, so even though there is some sudden change, we still can do something to make the goals is achieved, even though in a very limited situation, limited resources and also condition. And then continuous monitoring and evaluation ensure the continuous improvement of the program. So the program will keep up with the change in society. And for closing the program, I think I can show you the happiness of our students when they try to you can see the happiness of the students and also the society during the induction of the programs. Thank you for your attention, and that concludes my presentation. Back to Dr. Rokhmah.
Thank you very much, Dr. Rara, for I think it's a very comprehensive explanation about what you already did in Gajah Mada for the interprofessional education in the community. And I will invite back to all the three speakers. Yeah, let me just put on the spotlight and then. Okay, I will invite once again to all the participants to ask questions. And I think before answering to the questions, I would like to highlight all the best practices of our speakers, that every approach is different. And I think the key of community-based education is also about the context, what the community needs and what our students need. And from the first presentation from Dr. Saurabh mentioning about how to actively involve not only the students, but also for them to be part of the community, and then knowing what kind of approaches that we can use. And from Dr. Yudi's best practices, we can learn a lot about how important it is to supervise and also as part of the learning process and also the assessment process. And from Dr. Rara's presentation, we can learn that actually community-based education is a perfect opportunity for targeting the interprofessional collaborative competencies. We have several questions. Actually, this is Dr. Yudi asking to Dr. Rara. Dr. Yudi, you might want to ask yourself.
Thank you, Dr. Rahma and Dr. Rara also. My project in FAMER fellowship also in IPA and still continue until now, Dr. Rara. So the FAMER become the starting point actually for our university regarding the IPA. So I would like to, this year I want to make a research grant about the piloting. So the previous research during my fellowship project is about the how to perform need assessment and increase the awareness of IPE among 3 faculty stakeholders, actually the psychology, pharmacy, and medicine. But this year we start to make a piloting and also with limited and constraint in resource. So because the research grant not quite a lot, and then I would like to have an advice maybe from Dr. Rara, what kind of piloting maybe that we can call it IPA, not only lecturer between 2 different faculties or 2 different program students. Maybe you have advice where we start from where, and then the second one, how to advocate. I think the TFHC is one of the ideal inspiring model for IPA, but at the beginning, maybe there's some advocacy to the university stakeholder or to the other stakeholders, but how to initiate effective advocacy, maybe you have some tips for us. Thank you, Dr. Rara.
Yeah, thank you, Pak Yudi, from the question. But I think if there is still some constraints or challenges is too big, I think we can start by a small step. Yeah, so we don't need any giant step, but we start with the small step that can show that this is a very good and it's a good or excellent output. Yeah, for example, you can start not by conducting the community-based IPE, but you start small step with the kind of still the class-based IPE first. For example, you conducting some kind of discussion using a case study together between the medicine and the pharmacy students. You start with that, but then you show the impact, and it will be good what we call it, good arms, good ya sebagai senjata ampuh ya to starting the advocacy to the university level. And maybe or also maybe you can start by conducting the simulated based IPE, the simulation based IPE, like what Dr. Rokhmah conduct in our student who graduated the undergraduate and starting the co-assistant. So we conducting the simulation situation in our skill laboratory. So maybe you can also discuss it further with Dr. Rahmadia about the coordination between faculties. And I think there is also one question about that from other participants. I think we also doesn't have any experience yet conducting the coordination in the different faculties coordination, but maybe you can learn from our friends in Universitas Negeri Surakarta. They conducting a community-based IPE, but not like in UGM. The student is based on the primary healthcare, but based on the community. They are conducting the community-based with between the faculty of medicine, faculty of pharmacies, and also vocational school. So I think you can learn from them for the coordination. Yeah, so you can learn from the practitioner.
Yeah. Since we also have a FAMER fellow who are at
yeah,
Mbak
Bulan, yeah.
Alumni, a lot of MHP alumni from UNS. We will invite them at another series, Pak Yudi, since IPE is also another topic, a big theme that we will also invite speakers who had done best practices in IPE for the next for the next webinar. So since it is a very topical issue for everyone, and there are questions, I think I would like to invite, this is from Dr. Diani. Thank you, Dr. Rara, for the sharing. As you explained that community service should be based on the community partner condition. Is there any suggestion how to explore the community condition? Is it done before the program is developed, or students do it during the programs?
Yeah, so in my years, the community condition is, the condition of the community partner is assessed during the program in my years. But actually, before our institution conducting the whole program, the CFHC-IPE program, our institution, of course, already makes some kind of need assessment. What is the health problem in the community we use in Sleman Regency especially. And before we assign the student in year 1 in a family, in a family partner. Our partner, the EL, the instruktur lapangan, will select the family with certain characteristic. For example, they select family with health problems, but they also select family with have quiet, strong leadership, so they can help our student to communicate with other member of the communities. And also it's usually the family that easily to communicate with people, yeah, not a family with the lack of the communication skill or something like that. So we got a lot of help from our instruktur lapangan, yeah, to select the partner, the community partner. And for the year 3 program about the community health, we ask students to assess during the program, and then a student develop the intervention according to the need assessment. I hope it will answer your question, Dr. Diani.
Okay, thank you very much. And there is another question, I think, in the chat. It's quite long. Perhaps we could read. Perkenalkan Dr. Rara, Mr. Ermin from FKIK Win Malang. He told a story about his experience in 4 years of IPE to Calon Jamaah Haji, to the Hajj pilgrimage, using the family medicine approach with medicine, faculty of medicine, medicine study program and pharmacy study program, and with the health, I think, yeah, health office. And there are still some problems about, first, the model of the coordination. I think you already answered about that also, and how to map, I think, the learning objective of public health with the learning objective of public health students, like about the health, I think, health competencies for the students. And perhaps you can also share your experience, whether Gajah Mada already has collaboration or cooperation with the healthcare districts or primary healthcare. And is there any context in the health system to ensure or to empower the community to get benefit from the IPE activities, and about the strict scheduling between study programs? And I think that becomes all of the our challenge together. Please, Dr. Rara.
Yes, of course. Yeah, maybe it is easier to answer the last one. Yeah, this is also become a very challenging problem between us, yeah, in our situation, between student, DPL, EL, and also between the programs. Yeah, so we have a routine coordination meeting with all of those study program to choose a time as a scheduled time for CFHC-IPE. So right now in this moment we have every Friday morning is CFHC time So it is a protected time. So if we conducting activity during protected time, so we can ensure that the program can be running. And then about the organizational, we have a team, a managerial team in JFIC-IPE, and it come from those three study program, from the kedokteran, keperawatan, dan gizi kesehatan. And then the coordination level is conducting on those organizational level, and it's under the WD 1, ya, WD Academic, Vice Dean of Academic Affairs. And then about the LO, the learning objective, we are not kind of membagi. So we are trying to collect, at the first time, we are trying to collect all of the community related learning objective from all of those three prodi study programs. And then we are trying to choose which one will be achieved in JFIC-IPE and which one will be achieved in each study program. So that's what we conduct. So we are not kind of dividing the LOs. And then, is there any in organization outside the UUG? And of course, we have a strong MOU with the Sleman Regency, not only the health, what we call it, the health district office, yeah, but we have a strong MOU with the Sleman Regency. The MOU said that every faculty in UGM, so the MOU is in UGM level, so every activity, Tridharma activity conducting by Civitas Academia UGM can be conducted in all level in Sleman. So mudahnya adalah kita sebagai orang UGM bisa melakukan kegiatan Tridharma di semua tempat di Sleman, baik dari level paling rendah di RT sampai umumnya kita pakai dinas-dinas yang ada, dan ini berlaku secara umum di UGM. And we also develop an MOU, a specific MOU with health district office, because we use the primary health care also to as our main point in this JFIC-IPE, even though the student is not coming to the puskesmas, yeah, they are coming to the community. Is there any certain context untuk mencapai empower the community? Yes, I think not certain context actually, yeah. We just use the we usually use the platform, the framework that I put in our in my slide before, that we use those 5 levels of community participation, and we are trying to make those that student in the third year, especially in the third year, they have to reach out the powering, yeah, and that's the only framework that we use to in developing the curriculum. And
Thank you.
about the effect, yeah, manfaat. The effect, right now we are conducting the evaluation research on the effect of the IPE program for the head office district, and also for the public health. The research is not finished yet, but from our ELs we got some infos that they are feeling very happy because it helped them to conducting their program, the UKM program, ya, usaha kesehatan masyarakat. I think that things that I can share.
Okay. Thank you very much, Dr. Rara. There is still another question that was sent to me. The other has been answered about Desa Binaan, but there is other question about why the result is good, but the dropout is quite high. And can you analyze about whether you have?
Yeah, because we as a course developer doesn't put a very high, high expectation actually. As long as the students are able to develop program that can make people trying to change their habit, and they try to change and they participate in their programs. We are not counting on numbers. Yeah, so even though we have a target that at 10 families, but if then they only have 3 families actively following their program, so we accept that, yeah, because we know it's very hard for our student, yeah, very young people trying to be a member of the communities. It's not easy, yeah. So we don't put a very high expectation. So we say that the result is good because the student are able to develop the program that we ask, yeah, the learning path, yeah, they achieve the learning path. But yeah, sadly, the dropout is quite high, yeah, because of that's happened because of the pandemic situation. But now in post-pandemic era, the dropout number is not high, yeah. Most of them are still maintained because a student can easily access them, and if the family seems like or the community seems like ragu-ragu, the student are directly come to them, and then they are trying to negotiate with the communities, and then the community agree again to join the program and something like that. So it's quite different situation between the pandemic era and the post-pandemic era. Thank you, Dr. Rama.
Yeah. Now, I think this is for the last question. I think it's for everyone. I would like to invite also Dr. Yudi and Dr. Saurabh to answer. The last question is from Dr. Oscar. I think who will be the better mentor and or supervisor for the, I think I will take the broader context, not only IPE, but also for the community-based education. Is it from those lecturers or teachers who are from the faculty mentor, or is it better the community partner staff, for example, doctors or other healthcare professionals at the primary care? Perhaps Dr. Yudi, Dr. Rara, and Dr. Saurabh can give their views about this. Silakan, perhaps Dr. Yudi first.
Thank you, Dr. Rokhmah and Dr. Rara also, and also Dr. Oscar. It's quite challenges, but in our research result, actually at the qualitative basis, arose the theme about interprofessional collaboration. So if Dr. Rara explained about interprofessional education, we also capture the potential of interprofessional collaboration. Even in our own public health department, we try to put this as a concern because in the field, our medical students not only dealing with the primary healthcare supervisor as a doctor, as the head of Puskesmas, but also they are dealing with the midwifery. They also dealing with the sanitarian. They also follow how to conduct the community health program. And I think not only the primary mentor, but we have also to put the consider on interprofessional collaboration to enhance also the IPE in the future. So they can collaborate more and more, not only in the education process, but also in the collaboration process as a mentor or as a supervisor. So they should still have the primary mentor, but everybody could be a mentor. What we have to consider is how to capture all the feedback from the mentor to become more recorded by the student, and the student can put their lesson plans based on the feedback they gain from the interprofessional collaboration or mentorship. Maybe that's from my point of view of research. Thank you.
Thank you, Dr. Rara, please.
Yeah, I think will be the better mentor for the community based, yet because Dr. Rahma is broadening the question. I think as long as the faculty mentor is also being equipped with the ability to to facilitate the community based education, I think they can be a good mentor also. But I think because of the community education have a uniqueness in the term that student need to go to the community. Of course, the faculty mentor also need to go to the community to be able to give mentorship, to conduct the supervisor to our students. Yeah. So I think it's only about how the faculty mentor conducting the roles. So if you put the roles as a faculty mentor, also as a mentor and supervisor for say for IPE and also community-based education, so of course you need to put it in their job description, and also you have to empower them to be able to facilitate and supervise those activities.
Thank you, Dr. Rara. Dr. Saurabh, would you like to give your views on who should be the supervisors?
Ma'am, in my opinion and as well as experience, I think it is faculty who has to be the most important person, because their role not only lies in telling students what to do, but they also have to sensitize and prepare the community for the so-called going exposure that is going to happen. So faculty plays an important role. They have to be motivated themselves. Then only they can do something for the students by guiding them what has to be done, and at the same time prepare community also for the expectations and how they can benefit of this mutual interactions. So I think faculty. Thank you.
Thank you very much for sharing your opinions, our speakers. We've learned a lot this morning, I think, not only from the basic principles of community-based education, but also the approaches, the learning methods that we can use, the supervision, how important is it all of the supervisors, and how it is an opportunity for us to use community-based education as part of interprofessional education. Thank you to our speakers, very kind, and I think it's very helpful for the materials that you share, your experience, your best practice. And for participants, I would like you to all applause to our speakers, even though it's online. Thank you very much. And hopefully this is this webinar, which will help monthly. We would also like to invite for our participants to give their comments and also ideas about the future themes for our webinars. Please kindly fill in the evaluation form, which has been shared in that box. We will share to you what will be our next themes. There will be interprofessional education, there will be technology enhanced learning, and so on. So many issues that will be covered by this webinar, and hopefully this will also be special for not only our health profession education communities, but also in the best practice for our alumni and also FAMER fellows across Indonesia and in the Asia. Thank you very much, Dr. Rara, Dr. Saurabh, and also Dr. Yudi for sharing. See you again in the next webinar. And hopefully this session will also give insights for us to be best in our practice as a lecturer and also as our healthcare professionals. Thank you and see you again. Terima kasih banyak dan Bapak sudah menghadiri webinar ini. Sampai jumpa pada kesempatan berikutnya. Terima kasih. Hormat saya mewakili MHPE dan juga FAMER S2 IPK dan juga Departemen Pendidikan Kedokteran dan Bioetika. Thank you very much for coming, and I'll see you again in the next webinar. Thank you. See you.
Thank you.
Thank you all.
Thank you.
Thanks, Saurabh.
Thank you, sir. Thank you.
Makasih Pak Yudi, Saudara.
Sama Pak Yuyu.